So welcome. You know, they say taxes, death, and menopause for 50% of the world is a guarantee in life. And I am just so excited for you because I think you have two amazing presenters tonight who are really going to demystify this, give you frank and candid, pragmatic feedback on this state, and also some ideas for consideration. So with that, I'd like to introduce them. Our first, let me get on my readers. Our first speaker is Dr. Ruth Ann DeVera. She is an obstetrics gynecologist, Memorial Care Medical Group. Originally from Long Beach, attended Long Beach Poly High School. She decided to go back east for medical school and then came back out west to finish her residency at White Memorial Hospital. And we are also joined, so it's really nice to have you here. And then we're also with Dr. Jocelyn Craig. She is our medical director of the Pelvic Health Center at Long Beach Medical Center, which treats both men and women. Everyone has a pelvis. And she decided to do all of her, literally, training and education at UCI, School of Medicine here in Irvine. And she also currently lives in the area. So without further ado, I welcome just stay engaged, listen. You're going to really walk away with some great ideas. I'd ask that you keep in mind, like maybe challenge yourself to walk away with at least 2 to 3 new things that you've gleaned from this. And then there's going to be questions. And please write them down. We will collect them. Many times we find that there's some repetition. So if we all have a question on, vaginal atrophy, let's just ask it once. So anyway, without further ado, I'd like to please introduce Dr. Ruth Ann DeVera. Thank you.
All right. Hi, good evening. My name is Dr. Ruth Ann DeVera. As Rose had mentioned, I graduated my residency program from White Memorial, just up in East LA, and I graduated 10 years ago now. So when it came to graduating and my early years in practicing medicine, menopause was a rare topic of discussion in the clinical setting. I rarely had patients who wanted to talk about their symptoms, let alone to even entertain any possible treatment options. And nowadays, this is probably one of the most hot topics that we talk about in clinic. Several times a week, I have patients schedule appointments specifically dedicated to discuss their symptoms and to discuss which treatment options would be feasible for them. So a big topic for us to review tonight. So let's get into it. What is it? What is menopause? Menopause is retrospectively diagnosed, meaning it's not until we have 12 consecutive months of no menses can we go back and say, okay, that was my final menstrual period. There's really no great way or predictable tests to tell us when that final menstrual period is going to be. It is going to happen between the ages of 45 and 55 years for 95% of women, with the average age being 51. Symptoms usually will last for about 7.4 years. So once those symptoms, those hot flashes start, unfortunately for most of us, it's not just a couple weeks or a couple months. We're talking about a few years of this. When we talk about these definitions and menopause, there's different variations of the word menopause that you're going to hear. So I just wanted to bring to light, what are all of these, what are all of these different terms here? So perimenopause is also known as the menopause transition. This is the time frame that is going to start approximately 4 years before that final menstrual period, and it's the time frame that we notice our menses start to become irregular. How long, although it's about 4 years, it can vary in length and time for women. So it might last for 10 years for some women, it might last for about 2 years for some women. So that's what we refer to as perimenopause, those years leading up to that final menstrual period when your body's transitioning from a premenopausal woman to a postmenopausal woman. Premature menopause is when menopause happens between the ages of 40 and 45. So it's a woman who's experiencing that final menstrual period a little bit earlier than average. There are certain risk factors for this. So if you have a family history, so if your mom, your sisters went through menopause early, you're more likely to go through menopause early. A history of smoking, a history of cancer treatment. Typically, those cancer treatments are going to deplete your ovarian follicles, which eventually can lead to this early menopause or premature menopause. There's also such a thing of some women, unfortunately, going through menopause even earlier, before the age of 40. We label that something different, premature ovarian insufficiency. It comes with its own set of problems, kind of outside of today's topic, but unfortunately for some women, it can even happen earlier in their 30s. So menopause is what we had talked about on that last slide. It's when you have that final menstrual period. You're not going to be able to know that until you retrospectively look back and say, oh yeah, it's been 12 months since I last had my period. And postmenopause refers to the time frame after that final menstrual period. So once you meet that 12-month criteria of no menses, then you're now officially in your postmenopausal years. So yeah, we have all of this kind of nomenclature of menopause, and just to kind of clarify what these terms mean when you're discussing your symptoms or coming in for that clinic appointment. So this is a visual of what's happening to our estrogen levels. So why does this happen to us? Why do we go through menopause? Why do we have this menopause transition and then our postmenopausal year? It really comes down to this hormone, to our estrogen levels. When we're born, we have only a finite amount of follicles in our ovaries, and over the years, through ovulation, recruitment of those follicles, our follicle count is going to get less and less. So as our follicles decrease, our estrogen levels are also going to decrease. So you could see here at the age of 20, she has slightly lower estrogen levels. It's going to peak, and then it starts to decline. Our estrogen level never really becomes zero, but it's going to be dramatically decreased compared to what it was in our premenopause years, and that dramatic decrease leads to a lot of our symptoms, the irregular menses, the hot flashes, and everything else that comes with menopause. This is what we call the straw staging system. It does look a little bit messy, but this is a staging system that was designed by following over 3,000 women for a period of 15 years to try to give us a staging system that breaks down our reproductive years into these different time frames. This is a one-way street, so unfortunately, as we progress through our reproductive years, in this day of age, there's no way to really reverse it. So we start here with our menarche when we get that first menstrual period. We go through our reproductive years. This is when we're fertile. Most of us are, if we decide to, having children. This menopause transition that usually will occur 4 years prior to this final menstrual period. This final menstrual period here referring to that last menses, 12 years of no menstrual flow, and then we enter our postmenopausal years. Our menopause transition can be further divided into early and late menopause, and our symptoms are going to be much more obvious as we enter these late menopausal years. So as we enter the menopause transitions, our periods may be a little bit irregular. You know, we have these we still have menstrual flows, but the timing of when they come can be about plus or minus a week. You know, oh, I used to be very regular every 28 days, but now sometimes it's 3 weeks and I already got my period. Or, oh, maybe it's like 5 or 6 weeks and I'm getting my period. So we're starting to see changes, but the changes are going to be much more dramatic as we get closer and closer to menopause. So you could see here in that late menopausal transition, the intervals between our periods might even increase to greater than or equal to 60 days. Now they're coming months apart. This goes into a little bit more detail about what our hormone levels are doing during this time frame. What I do want to mention about checking our hormone levels, that's a frequent request I get when women come in to talk about menopause, is, well, doc, can we check my hormone levels? I want to see what my hormones are doing. And I have no issue checking the hormone levels, especially if it's going to bring some comfort to patients to understand what's going on with their body. But there are definitely limitations to how much information that blood test is going to give us. Our hormone levels are highly variable, and if we get a normal hormone level, but you're 48, having hot flashes, your periods are every 3 months, I would say what a woman is clinically experiencing and the symptoms she's telling me that she's suffering with are far going to outweigh what that lab test shows me. So we might check a blood test 1 month, it says everything's normal, but we might check it 3 or 6 months later, and then, we see your estrogen levels going down, we see that FSH level going up. So they're unreliable. It's a safe test to do. It's pretty non-invasive, have your blood test done, but the amount of knowledge that blood test is going to give us is really not going to outweigh what you're telling me you're experiencing, which at the end of the day, that's the most important thing, is we're coming to see the doctor, discuss our symptoms, and hopefully get treatment to make us feel better, not necessarily to make our lab value change on a piece of paper. Okay? So we all have symptoms. The degree as to how many of these symptoms we're going to experience, how bad are they going to be, how long are they going to last for, is going to vary from person to person. So what are those symptoms? The fun one, the most popular one, are hot flashes. 80% of women are going to experience hot flashes. Of those 80%, only about 20 to 30% will actually come into the office to discuss them. Other symptoms, as we discussed, those irregular periods. Breast tenderness is another common symptom. You may have never had to deal with breast tenderness your whole life, and here you are, mid-40s, late 40s, and all of a sudden coming in because you're worried about your breasts being tender. It's menopause. Premenopausal syndrome, or PMS. This refers to having more PMS symptoms as we approach our menopausal years. That time frame 1 or 2 weeks before your period comes, the mood swings, the food cravings, the fatigue, the bloating, it does get more pronounced as we go through this menopause transition and menopause. Mood swings, insomnia, sleep disturbance, fatigue, sexual dysfunction, which we'll go into more, urinary incontinence, and bowel issues as well. So it's not just our reproductive system that's going to be affected with our menses, it's really our whole bodies that's going to be affected. Dr. Craig was kind enough to share this photo that she took on a vacation, which I do like here. It emphasizes the fact that this is a whole body phenomenon, that it's not just one symptom or one isolated organ system that's going to be affected, but our body as a whole. And if we take a step back further, if we're talking about these issues that we're going to deal with in our 40s, our 50s, our 60s, this is also a time in our life that's just busy in general. Menopause doesn't happen in a bubble. We have busy lives. So this patchwork also represents us as a member of a family, as of society. So we're asked to, or required to navigate this menopause transition with work, still being a part of this, with being caregivers for our children, aging parents, with being responsible for maintaining some of our social relationships with a significant partner, with friends, with participating as a member of society. So the patchwork not just represents us and our physical individual experiences, but also that we go through this, but still have all of these other responsibilities to maintain. So this is a survey that was asking women to note which symptom was the most difficult to deal with in their work environment. So number 1 is the hot flashes. This is most likely because it's the most common symptom that we're going to experience. But you could see, as that last imagery was alluding to, that this is also going to affect so many other things in our lives. Lack of sleep, joints, these aches and pains, night sweats, fatigue, anxiety. I mean, the list just goes on as to how many parts of our body are affected. We're not really quite sure, well, why does the hot flash happen? So it's not really well understood yet. We think it's most likely due to the relationship of the part of our brain that controls our body temperature, what we refer to as the hypothalamus, and its relationship to estrogen. So as our estrogen decreases, it affects this part of our brain that leads to these hot flashes. When women experience hot flashes, most of the time they're going to have hot flashes several times during the day, and also more pronounced at night. When they happen at nighttime, we refer to them as night sweats. Usually lasts for a couple minutes. It can start centered in the chest or face and then rapidly spread to the rest of the body. Hot flashes can also be associated with chills afterwards, with a sense of also anxiety. When you get a hot flash, sometimes that can trigger some anxiety in women as well. I'm going to turn the talk over to Dr. Craig, our urogynecologist, to talk about the changes that menopause has on our vagina and our lower part.
Hi there, I'm Jocelyn Craig, and I do head the pelvic health program at the hospital, but I also have a private practice in urogynecology and reconstructive pelvic surgery. So we deal with issues of urinary incontinence, fecal incontinence, prolapse, chronic bladder infections, chronic pelvic pain, but often a lot of this has to do with changes in menopause as well. So Dr. DeVera and I are going to go back and forth just a little bit, but I'm going to talk a little bit about some of the sexual health and the incontinence as well. I will just say, though, we came up with this talk months ago, and I take it very seriously that for my office, we should have good magazines in the lobby. And so I think I should preview them, too. So I went and bought the new Oprah magazine, and if any of you look at it, you'll see the entire thing is about menopause. So that makes me really happy, because we really need to talk about this and demystify it and actually celebrate a natural life transition, right? But some of the things that happen are not fun, all right? One of the first pages in the magazine, she says, "Buckle up, it's about to get weird." And and that's true. But the vagina is very much affected by estrogen levels, and there is something called genitourinary syndrome of menopause, because the lack of estrogen feels like dryness, feels like a urinary tract infection, feels like a vaginal infection, and that dryness can be part of issues with sexual health, but also with your urinary health as well. Vaginal estrogen is one of several components that keeps the vagina its normal length, right? It also, the vagina is for birthing, right? So it's supposed to distend. So when there's no estrogen in the body anymore, it can also affect the vagina, and there's actually shortening of the vagina, which we call stenosis. The tissue also thins, and so the quality makes it more susceptible to infections and abrasions as well. And there can be changes in the skin on the outside, which we call the vulva. So this is a picture of this showing this as well. And we'll talk a little bit more about it as we go along, but vaginal estrogen is very safe. There are truly no studies showing that vaginal estrogen causes cancer. That said, there's definitely situations where women should not use vaginal estrogen. So I would never say that everyone should use it, but more women can use vaginal estrogen than have been told that they can. So it improves the strength of the tissue, but it also improves lubrication, and it improves blood flow to the area. Another reason that is important, not just for sexual intercourse, vaginal estrogen stabilizes bacteria that's normally found in the vagina. Bacteria in the vagina causes bladder infections most of the time. So when we treat bladder infections, we actually give vaginal estrogen. We're gonna hold till the end for the questions. Okay? Yeah. Yes. Increases lubrication and blood flow. Yeah. So libido can definitely be affected through menopause, right? But that's multifactorial. So vaginal estrogen definitely is one of those factors. If If sex was pleasurable before and now it's painful, of course it's going to affect your libido and desire to be sexually active. There are different ways to be sexually active, though, as well. So that is something that we talk about. But there can be weight and physical changes that are unrelated to vaginal health, right? As we get older, there can be hip issues, back issues, other chronic health issues as well. Can affect our sexual pleasure and our sexual activity, and that can have a psychological effect as well. So the mood changes that come along with menopause are also real and can be treated. There are, as I said before, there's multiple components that affect vaginal health. So estrogen is one of them, but there's also elastin, fibrin, collagen, and the pelvic floor muscles. So elastin and fibrin are elements that we're born with, and again, that affects the vagina, and the vagina should be able to distend and contract, right? They're critical in support of your pelvic organs. We are probably born with a certain amount of elastin and fibrin. My research and fellowship was in stem cells and the vagina and the rectum. So we make our own stem cells as well, and we inherit our connective tissue from our ancestors as well. So that component we can't really change very much, all right? Collagen is all over our bodies. There's different types of collagen. In the vagina, there's type 1 and 2, and as we go through menopause, it's inactive anymore. So there are ways to stimulate it, but that is also one of the reasons that it affects lubrication and distendability. Our pelvic floor muscles are always active. The pelvis is sort of a basket weave of muscles, and they're always active, right? If we had to think about our pelvic floor muscles all the time, we wouldn't be able to think about anything else. But think about your urethra, your rectum, they're always tight, okay? They're keeping you continent. But those muscles can be damaged with vaginal deliveries, with surgeries. You can have spasm in those muscles related to back surgeries, hip surgeries. So that's another component that also can be a factor with pain with intercourse in menopause. Let's see. I am going to talk about urinary incontinence. Each type of incontinence could be its own lecture, but we are going to talk about these as well. Overactive bladder is a syndrome of symptoms. So going to the bathroom frequently, can't delay it, getting up at night, and leakage, all right? That has its own spectrum of treatment, but it's definitely affected by estrogen. The urethra has receptors for estrogen, all right, as does the base of the bladder. The urethra can shorten with age as well and with lack of estrogen. So again, a really good reason to give women vaginal estrogen. Stress incontinence is the leakage of urine with coughing, sneezing, laughing, and that's more of an anatomical problem, but it also is affected by estrogen, okay? So before we talk about bladder dysfunction, we need to talk about normal bladder function. So this is just a picture showing what happens, all right? There on the far side there, as you are going through your day, having your mochaccino, venti, whatever, your bladder is filling, and the bladder is designed to fill without increasing its internal pressure. We get responses to urinate while the bladder fills. The first response is kind of like, hey, there's something here. Most women can delay that, right, and let it go a little further. Then you get a second desire to urinate. Hey, you really need to go to the bathroom. A larger portion of women will go to the bathroom, or humans rather. Then you finally get a normal desire to urinate. And at that point, the bladder that was relaxed as it's filling and the urethra that was tight, they reverse. The bladder is supposed to squeeze as the urethra opens, okay? But if that doesn't work that way, then we get dysfunction as far as the bladder and leakage, all right? So here's a picture that shows the different types of urinary incontinence and how they can overlap. And the point here is that you can have more than one issue with your bladder. And those treatment options sort of V outwards. There's behavioral issues that we talk about, lifestyle issues, physical therapy, but then all of these have their own surgeries and their own medications as well, okay? But depending on what research you look at, 1 in 4 women will have issues with urinary incontinence or a pelvic floor issue in their lifetime. All right, I don't remember what's ahead. I'm going to look and see. All right, so I think Dr. DeVera is going to get into actual estrogen and progesterone discussion next, but this slide is just talking about overall health. And often patients will come to us and say, well, I want to do something natural. I don't want to take a medicine. I don't want to have surgery. I want to do something natural. And I say, great, because your overall health is important before menopause and after menopause. And having a healthy lifestyle is going to help you go through some of these really huge body changes. Other things happen, like that photograph I took of the Netherlands. It's different areas of our body that are affected, right? So there's an increase, our heart risk, our heart disease increases after menopause. I think, isn't February Women's Cardiac Health Month, but women and heart disease have its own experience, and that changes after we go through menopause. Our bone density is reaching its maximum level in our 30s and our 40s, but after menopause, that's when osteoporosis becomes an issue. So staying active, getting weight-bearing exercise, making sure you're getting calcium, vitamin D, looking at your fat intake, salt intake, all of those things are huge. As Dr. DeVera mentioned, patients who smoke can sometimes go through an earlier menopause as well. So if you smoke, stop. If you don't, try not to start, or back off on if you're able to, okay? Alcohol intake, there's a small amount of alcohol can be heart healthy, but then larger amounts of it can be a risk for breast cancer, and it can also increase the flushing that happens with menopause. Stress reduction, anxiety, addressing those things, sleep deprivation that happens with menopause is a real thing. The problem with sleep deprivation is it affects our cortisol levels, which then in turn makes it hard for us to lose weight, right? So really looking at sleep hygiene and stress reduction is very, very important, okay? All right, you're it.
All right, so it sounds like a really depressing topic, like, oh my gosh, I'm going to experience all of these things, like there's just nothing I can do about this, but there are treatment options. When we talk about treatment options, I would say the biggest thing to keep in mind is that it's all individualized. Well, how bad are your symptoms? What are your goals? What's your risk tolerance? Because nothing comes for free, so every time we talk about a treatment, there's also the risk to the treatment. So we'll go through that today. So the gold standard for treatment, what's going to work the best? Well, if we're talking about an issue that's really related to decreasing estrogen levels, well, why don't we take estrogen? So estrogen is the medication that is going to best address the symptoms like hot flashes. When we go back to those slides that list like a dozen different symptoms we have, the hormone replacement therapy that we have available to us, it doesn't address everything. So it does really work great for things like hot flashes, things like sleeping at night, but it's not going to help with every single symptom on that list. So I try to elucidate with patients, well, what is it mainly that's bothering you, and how effective or how likely do I think our treatment's going to work? So what is HRT? HRT is usually prescribing women estrogen with or without progesterone. Estrogen being the key component, but estrogen also coming with its risks. So if a woman has her uterus still intact, she has not had a hysterectomy for whatever indication in the past, then we also have to prescribe progesterone along with the estrogen for the protective benefits of the progesterone on the uterus. So these are probably the two most popular formulations. Any supplementation of estrogen or estrogen plus progesterone is used to treat menopause symptoms. And that would probably be the biggest difference or delineating factor as to why we use estrogen alone or estrogen plus progesterone, really mainly if that woman still has her uterus intact. So the WHI, or the Women's Health Initiative, this was a large pivotal study, and by large, I think it was 160,000 women enrolled in this study that took place between the 90s and the early 2000s. I think the results of this study is a big reason why during my residency training and my early years of practicing, hormone replacement therapy was really just was not something that women were willing to take because of the results of the study. So these are the types of progesterones and estrogens that were prescribed in this trial. Not as important as what the results were. You know, why was this study done? What did they find? And why did I see not many patients seeking treatment with HRT or with hormone replacement therapy? So again, 161,000 women. They were ages 50 to 79 years of age. The average age in this study was 63. And the main point of the study was that they wanted to see if prescribing hormone replacement therapy would decrease cardiovascular disease. Hormone replacement therapy was very popularly prescribed for that indication. Like, oh, take hormones, it's going to protect your heart, it's going to reduce your risk of stroke. There was some small observational studies that showed that. So they said, okay, well, why don't we do a randomized control trial, which is kind of like the best research study that you can do. Let's do a good quality research study where we give women hormones and then we follow them out and see, okay, well, what's going to happen? Are we going to truly see that they have less risk of cardiovascular disease? Unfortunately, we found the opposite. We found that going on hormone replacement therapy actually increases your cardiovascular disease. So that was why the study was terminated early, was from a safety standpoint because of that increased risk. We have to remember, though, the women enrolled in this study were age 63, so they were older. So although this was a great big study, many participants, randomized controlled trial, you know, this well-designed study, there are limitations to the study. The average age of the women in the trial were older than what a lot of the ages of the women are seeking treatment. Many women come in their 40s, come in their 50s, their early menopausal years to discuss symptoms and seek treatment. Also, the type of hormones that were used in the trial are different than most of the hormones that are used nowadays. These were all oral preparations. Nowadays, much of the estrogen is given transdermally, whether it's a patch or a cream, because of the better safety efficacy with a transdermal approach. It doesn't bypass your liver and have liver metabolism, and therefore should have less risk on your clotting factors, and thus less risk for cardiovascular disease. So here is the estrogen only, again, terminated at 8 months. They saw an increased risk of stroke. However, there was a decreased risk of hip fracture and then no difference in mortality. As we discussed, estrogen is also prescribed with progesterone in women who have a uterus. In this group, they did see an increased risk of breast cancer. This was not the primary endpoint. Their main goal was to evaluate hormones in relation to cardiovascular disease. But in the estrogen plus progesterone group, they did see that there was a slightly increased risk of breast cancer. Interestingly enough, in the previous group that I mentioned, the women who were only taking estrogen, they actually saw a decreased risk of breast cancer in those women. And then with any of the hormone replacement therapy, we also do see a decreased risk of osteoporosis. So although it may sound scary, like, oh, great, now, doc, you're telling me I'm going to go through menopause, have all these symptoms, and you have these medications, but I might die of a stroke. Well, no, it is a slightly increased risk, but there are also limitations to how we interpret this WHI study. So here again is outlining the outcomes of this WHI study, which was, again, a big landmark pivotal study because what we thought we were going to see, mainly in regards to coronary artery disease, we did not see. Here it says that the breast cancer incidence did not increase over placebo. Again, I'm sorry, this is a little confusing, but this is with the estrogen plus progesterone arm, there was a slightly increased risk. Blood clots increased significantly after age 60, stroke increased after the age of 60, protective for colorectal cancer and hip fracture, again, because hormones do protect against osteoporosis. Here are some caveats of the study. It didn't study menopausal symptoms. Women in their 50s were underrepresented in this study. The average age was 63 in the study. And then, as I discussed, only oral hormone replacement therapy was used. And nowadays, there's vaginal applications, such as what Dr. Craig was mentioning, which is considered to be very safe. And then there's also topical estrogen, which has less risk than the types of hormones that were used in this large trial. A common question I get asked is bioidentical hormones. Bioidentical hormones, what it's supposed to represent are hormones that mimic the natural types of estrogens and progesterones that our body makes. That's what bioidentical means. There's no study that shows bioidentical hormones are any safer or more effective than what your traditional prescription hormones are gonna give you. The other caveat with bioidentical hormones is these are made by compounding pharmacies. Compounding pharmacies are not your typical Rite Aid or CVS or Vaughn's pharmacies. These are pharmacies where they have a compounding pharmacist who is making those formulations, those different types of creams and percentages and potencies in the pharmacy themselves. So it's a less regulated type of medication to receive. So although a lot of women will say, well, it's bioidentical, it's more natural, it should be safer, my friend's taking bioidentical, I have to warn them that there's no research that shows it's any safer. And then you also have to understand you may or may not be getting what you're actually written on the prescription for because they are made in-house in a pharmacy that's less regulated. So bioidentical hormones are not recommended. If you have a patient who really truly has an allergy, well, you wrote me that prescription for a patch, I put it on and I had a big allergic reaction, and this is really the only thing that we can go to that works for that patient, then by all means it does have its place, but not my go-to for treatment. So hormone replacement therapy, our takeaway points here. So we can treat with hormone replacement therapy. Despite what the WHI studied or showed, there were limitations to their study. Their patients were older. The types of hormones that they use are really not the types of hormones that we use nowadays. Do give the lowest dose for the shortest amount of time to treat the symptoms. Don't start hormone replacement therapy greater than 10 years for menopause. The older you start hormone replacement therapy, the further away you are from that final menstrual period, the higher the risks do become. So starting hormone replacement therapy in your 40s, your early 50s, your perimenopausal or your last menstrual period was 2 or 3 years ago does come with less risk than starting at the age of 60 and above. I would be very, very, very cautious to start any woman who's 60 and over or 10 years from her final menstrual period on hormone replacement therapy because the risks are greater. So an average risk woman less than 5 years of hormone replacement therapy appears safe. Up to 10 years is acceptable in low-risk women with bothersome symptoms. So typically, as you get further and further away from that final menstrual period, the less likely you're going to need your hormones. So at the 5-year mark, I usually offer patients, okay, well, why don't we try to start tapering you? Let's see if you need this dose, or let's see if we can get you off of it. So tapering the dose down to see if she's going to rebound and have more of those symptoms. If she does, then we know, okay, it's not quite time yet. We need to go back to your old dose and continue the hormones. There are some women who are in their 70s, 80s. They've tried to taper before and they just can't. So there are some women who will fall outside of this guideline. So there are non-hormonal treatment options for women who are not candidates for hormone replacement therapy. So this would be a big topic to discuss in women who have already had a heart attack or stroke, who have had prior breast cancer, where the risk of hormone replacement therapy would just not be acceptable. This includes antidepressants. Paxil is a commonly one prescribed. Neurontin, or gabapentin is its other name, oxybutynin to help address some of the bladder issues. Clonidine is a blood pressure medication but can also help reduce hot flashes. And this newer medication called Veozah, which is a non-hormonal medication specifically indicated for the treatment of hot flashes. Lifestyle changes, non-medication ways to help treat some of these menopausal symptoms. There's various cooling techniques. There's some of those portable fans. I see some women hook up onto their cell phones or have around their neck. There's also these body mist sprays that I've seen some patients use. It kind of has like a menthol ingredient, so you could spray it when you have your hot flash, and it can bring a cooling effect. Weight is related to your hot flashes and how bad menopause is going to be for you. So controlling your weight loss, if you're overweight or obese, can also improve your menopausal symptoms. Exercise, yoga, especially from like a mind-body connection, helping to reduce that stress, reduce the cortisol. So exercise and yoga can help. Cognitive behavioral therapy, mindfulness, clinical hypnosis, acupuncture. These are all ways to non-medically treat these symptoms. Veozah, this is that medication on the previous slide, this non-hormonal treatment for vasomotor symptoms. It is an oral medication that's indicated to treat moderate to severe hot flashes. So it works specifically on the receptor in our brain that is related to triggering that hot flash. So it blocks that receptor, and therefore, with that mechanism, can help control hot flashes without the exposure to hormones. It's a relatively new medication. I think it either came out last year or this year. I think they had a commercial during the Super Bowl this year too to advertise. So this is a fairly new medication. With newer medications, always, or one of the big barriers to it is insurance coverage, but something that we have now in our toolbox to help with these symptoms. Dietary supplements. So there's tons of supplements out there that claim they're going to help with X, Y, and Z. These are supplements that have evidence behind them to actually help with these menopause symptoms. So vitamin E, black cohosh, ginseng, Libesia pumila, omega-3 supplements as well. Omega-3 supplements most likely from helping to decrease inflammation in general. Vaginal estrogen, I know Dr. Craig had gone into vaginal estrogen and its place, so I won't go into too much detail about the vaginal estrogen.
All right, so this is just a little plug again for vaginal estrogen. Reverses atrophy, can increase libido, can improve orgasm because of improved lubrication and blood flow. And there's different ways to deliver it. So vaginal estrogen can come in a cream, tablet. There's rings that last for 90 days. There's gels, right, that can be used. At the bottom are some moisturizers. So those are not going to change the tissue, but they can help for dryness in between the times you're using estrogen. Replens and Luvina are things you can get over the counter. Coconut oil can be very similar to body secretions for people. I've had patients, especially if they've had cancer, that might be really susceptible to some of the things you get over the counter, extra chemicals. So honestly, Crisco, olive oil, coconut oil can be used as lubricants, but they're not going to change the tissue. Sometimes patients will ask me for lidocaine, and we actually do use that in certain situations, but lidocaine used on vaginal tissue over time actually dries it out. So while it sounds like it could be good, it is not always. And evening primrose as well, which you can get at a health food store. Sometimes pain is not related to hormones, though, right, or the hormone changes. It might be a combination. And so vaginal estrogen is treating the hormonal component, but then there's an issue of muscle spasm as well. And that's why the picture of Botox is here. At the Pelvic Health Center, we do try to send patients to physical therapy as often as they want to go and as often as it's indicated. There are physical therapists who are trained in pelvic floor physical therapy, so they have to go through specialized training, and they can treat males and females. So it's just like going to any other physical therapist, but it's dealing with pelvic health disorders. And again, there's a lot of crossover with back and hip issues as well. Sometimes that can address pain. It can address urinary issues or bowel issues. But when it's not enough, you can add other medications. So I do use compounded medications in the vagina for muscle spasm, muscle relaxation. We do injections into the pelvic floor muscles too, with pain medicine that only lasts for a couple hours, which sometimes combined with physical therapy can help patients propel further through their treatment. You can actually use Botox in the vagina as well for muscle spasm. Unfortunately, it's not covered by insurance, but it absolutely works. On the other side, Botox is now used in the bladder for urinary incontinence as well, and it is covered by insurance. So when patients have overactive bladder and urge incontinence, that's the leakage where I'm trying to reach the bathroom and I can't reach it in time. When medications or lifestyle or physical therapy do not work, Botox in the bladder is actually an option, right? We inject it into the muscle of the bladder itself. It lasts for 6 to 12 months and then it wears off. So you may have just heard about it cosmetically, but it's used for spasm in other areas of the body, including the vagina and including the bladder. So that's why that picture's there. I just want to say, nowadays there are so many different ways to find out about your pelvic floor health and all these issues related to menopause. So Rosie just happens to be an app that you can download that talks about sexual health. There is advice and information for patients, for doctors, for couples, but there's apps for other things as well. There's bowel apps, there's urinary apps. There's a really cool app that will tell you if you have urinary incontinence or you need to go frequently, when you can leave a movie and not miss the good part. So, see, there's just a little bit. It's called Run Pee. Run Pee, yeah. It will tell you, let's see, I haven't been to a movie in so long, but Mission Impossible, it will say 23 minutes in, it gets kind of boring, you can go to the bathroom. So my point is nowadays there's apps for everything, including our sexual health, which is related to changes of menopause as well. Back to physical therapy and pain. When we send patients to physical therapy, it's just like any kind of other physical therapy, right? They give you some things to do, whether it's exercises or stretches or things to do, and then they send you home to do it, right? So those improvements only last if you continue to do those treatments. But sometimes they use dilators, really just like if you have a crook in your neck or your back, to find those areas where there's tension. Patients sometimes can use dilators for muscle spasm. Sometimes if there's atrophy of the vagina and there's been lack of estrogen for a long time, you need dilators just to open up the vagina itself. And we train people how to use those. And I've trained patients and also partners how to use those as well. So just another thing to be aware of. Back to urinary incontinence. So there's a whole level of treatment options. And when patients come to see us for any pelvic health issue, but especially urinary incontinence, we try to talk about every level of treatment, all right? And I will start with lifestyle. I love coffee, but there's really good studies that show if you're getting more than 24 ounces of caffeine a day, whether it's hot chocolate, coffee, tea, soda, it will give you overactive bladder and potentially leakage of urine. Carbonated drinks, a lot of people like to drink sparkling water. It has carbonation in it, though, which irritates the bladder. So what our bodies need most of the time in fluids is pure water. Doesn't mean you can't have sodas or alcohol or carbonated beverages, but you do need to limit them. Dr. DeVera mentioned also weight loss can be linked with menopause issues, but it can with urinary incontinence as well. There's very good studies that show if somebody is in a category of obesity for their BMI, if they lose even 10% of their body weight, their urinary incontinence improves by 40%. So sometimes that's easier said than done, right? You say, I would go running or I'd go walking, but I leak the whole time. So we don't deny people treatment because of that, but just knowing and motivating you to the best you can. Exercise and weight loss through diet as well whenever possible. Pelvic floor exercises can be done nowadays online, YouTube, but a physical therapy site can also do them as well. And here's why having another human explain this to you is super important. Sometimes it's not an issue of needing to tighten your muscles more so you don't leak urine. It's the fact that they're already too tight. And that's not something that we innately know about, right? So sometimes if somebody's leaking urine, they're coughing, they're already so tight, there's nowhere for the muscle to go. So a physical therapist can help you understand that and do these exercises correctly, right? If you've sat through even one block of commercials on the TV, you've probably seen ads for oral medications for overactive bladder and urgent incontinence, and there's all sorts of different ones. They have different interactions, so that's definitely something that should be discussed with the physician. But there's medications if some of these conservative things fail. We already talked about vaginal estrogen, and then there's surgical treatment for urinary incontinence, and it depends on the type of urinary incontinence you have, but there's all sorts of different surgical treatments, and so we try to go through all of those with patients. So I think at this point we're going to close, but I just want to close with this quote that's in the Oprah magazine. She should pay me money for talking about her. But it says in there, you can't outrun, out-earn, or out-exercise the big M. The menopause train is coming no matter what. I've been to this facility multiple times for weddings, for bar mitzvahs. I've never been for a menopause party. But that could be a new trend, right? But this is a life transition that's just as natural as that, right? And as Rose said in the beginning, it's inevitable for 50% of the population. We are trying to normalize it and talk about it more, and I really think that we should celebrate it. Maybe you should even register for dishes when you go through menopause after your children have destroyed everything. But we should really celebrate it, and we mostly want you to know that there are so many treatment options out there, and we're happy to discuss any of this with you, and I hope that this information tonight was helpful. So thank you.
So how many people walked away with 2 to 3 things? A multiplier add on to that. Well, we just want to thank you both so much for your presentation this evening. And I'm sure it's elicited a few questions. And so if you'd like, happy to take them, raise your hands, or we can just write them down and happy to collect them. And we'll just read them to our physicians as well. But I do have some, and everyone who's attending online, please drop in your questions in the chat box. So I'll just start with one, though, that we did receive online. So we have a guest who tried PT at WAMOH, okay, and it didn't work. What else could she do without surgical implantation? And maybe if you want to come up here.
Well, I would say go back to your physician, right, and talk about that. So without knowing what the details were as far as was it because of prolapse or urinary fecal incontinence or pain, hard to say. But I would say go back. It's not going to solve everything, but sometimes physical therapy is helpful before you have a surgery. Sometimes it helps you also decide, hey, maybe I need something more than this, and sometimes it solves the problem. Yeah.
Dr. Javera, what do you recommend treatment-wise? Are there any that exist for sleep disturbance for women who have a history of breast cancer?
So if we're talking about just sleep-related issues, and with a history of breast cancer, hormones are really going to be off the table. Progesterone, estrogen, I would not offer. Other medications, there are some simple over-the-counter medications that can be taken. Melatonin, Unisom, specifically for sleep. Trazodone can be prescribed for sleep. Having a really good sleep hygiene, a good sleep procedure before you go to sleep, making sure your digital devices are gone, that you're turning down the lights, that you really prepare your body for sleep can also help. So good sleep hygiene. So there are various prescription medications. There's over-the-counter medications. There's herbal things that can be tried, like having chamomile tea. At night, relax, lights are dim. And it might, for patients who have really severe issues going to sleep, it might have to be a combination of all of those things.
Okay, thank you. We have a woman back here who has a question, if you don't mind. Just so our guests online can hear it.
Yeah, just two quick questions. I'm over 70 and I'm on estradiol. Should I include progesterone? And the second question is, I'm over 70, I'm still having hot flashes. A gynecologist told me, or a hormone specialist told me I might have hot flashes forever. Is that true?
Ouch.
We're gonna split that up, but I'm gonna say one more thing about the sleep hygiene. Sometimes gabapentin can be helpful with sleep hygiene, right? So talking to your physician about that. And then a plug about Veoza. It's only been on the market less than a year, I think. But that would be safe in a patient who's had breast cancer. And it takes about a week to 2 weeks to notice if it's gonna be helpful. So the improvement should be within that time. But that would be something that I would recommend to a breast cancer patient that they ask their physician about. You can answer.
So generally speaking, if you have your uterus in place still, if you have a uterus, estrogen should always be given with progesterone. There are some women who have hot flashes all the time, no matter if they're 70, they're 80, they're 90, they've been on hormone replacement therapy, and they're never able to wean off of it. That is, the smaller percentage of women. Most women are going to need it for 5 to 7 years and will be able to eventually come off of it. But yeah, I would encourage you to speak to your physician about the hormones that you're currently on, and it may or may not need to get tweaked. It's hard for me to specifically say without knowing your full history.
Thank you. We have another question.
Yes, if your brain tells you that you have to go to the bathroom, urinate, but you don't have time, so you're holding that in your bladder, So my question is, does that eventually harm the kidney, that you're disallowing that flow to go through the urethra and out?
Yeah. So I think a lot of women were
I have two questions.
told when they were younger, go pee before we leave the house, go pee before you leave school, right? So we were taught to just go just in case, right, sometimes. Also, we were taught if you hold your urine too long, it could damage your kidneys, which can be true, but we're talking like 6 to 8 hours of holding, So it's normal for you to go to the bathroom and urinate every 2 to 3 hours. That would be normal, okay? Urinating 8 times in 24 hours is considered normal, all right? So one of the things that happens, though, and it happens to me too, is I go, I'm just gonna do one more thing over here, I'm just gonna do one more thing over here, and the bladder is telling you, you need to go to the bathroom. So there's a lot of potential for dysfunction in there, but sometimes we cause that by saying, I don't have time, I wanna do one more thing, right? So then that's something to talk to your doctor about and see I have people do a diary. We do a 24-hour diary and see what you're drinking, how often you go, how much you're holding. Is it normal or not? Okay?
And my last question is, if you cannot hold your urine, you have to, keep going to the bathroom. Is that because of the Kegel muscle, that muscle, that pelvic floor has deflated? The muscle is no more good?
Yeah. The name Kegel is named after Dr. Kegel, who invented the technique of squeezing your muscles that way. And he had great success. And you know why? He admitted his patients to the hospital. This is before insurance companies, because all they did all day was do these exercises for the study. So Kegel exercises is learning to contract your what are called levator muscles in the pelvic floor and tightening them. I find that sometimes what's happened, we haven't explained to patients, your body doesn't do that naturally. You're supposed to learn to do those exercises so that when you cough, sneeze, or laugh, you know how to do them beforehand to decrease the leakage, all right? And remember I said sometimes they can be too tight as well, so sometimes it's because they're too tight, and sometimes it's because you had 48 ounces of Diet Coke and you really need to go to the bathroom. So there's all sorts of different reasons for that. But I will say something else. We try to tell patients, don't just go to the bathroom just in case. I mean, if you're going to get in the car and go somewhere, Of course you should go to the bathroom. You're going to be in the car for 3 hours. You don't know where the bathroom is. But what happens is the bladder is a dynamic muscle. It's supposed to fill and empty. And if you are teaching it over and over, I'm just going to go just in case, it learns to warn you earlier and earlier. All right? So that's why it's so, there's so many layers to it. And that's why talking to a physician independently is a good idea.
I have a question from one of our guests. Can women who are predisposed to blood clots take vaginal estrogen?
I mean, it just depends.
Yeah, I would say if it's predisposed, meaning that it's a family history of blood clots in their mom, their sisters or brothers, it's not a personal history. Again, it should be a discussion with the physician to really get into all of the specifics. Well, what is that predisposition? Is it a genetic mutation? Do you have that genetic mutation? But overall, vaginal estrogen is safe for most women. So it sounds like a personal discussion and individualized decision to make to really hone in on, well, what is the predisposition?
Good information. I see, too, we have a question up here in the front, if you don't mind using the mic for...
Sure, about menopause. When is the time, if you were having IUD in place, the time that you will feel the menopause if you don't have like menstrual periods?
So having an IUD in place, especially an IUD that suppresses your menses, so you don't really have those menstrual changes that you can look at to let you know if you're going through that menopause transition, it could be hard to know. So if on average women go through menopause at the age of 51, on average women will start to have menopause symptoms 4 years prior to that, so at the age of 47, then that would, I would say, be the time frame that you can count on that you're most likely to have menopause symptoms. But there are some women who go through the menopause transition and absolutely have no symptoms at all. They look back and they're like, oh my gosh, I had my last period. I never even knew that was coming. So it could be hard to tell, but if we go by what happens usually, somewhere between 47 and 51 years.
So until what age is recommend to remove the IUD?
So if you have an IUD in place, I would keep it in until 51, 52, when you are most likely postmenopausal by that time frame and you are highly unlikely to conceive.
Thanks.
If a person has been on estrogen blockers for 10 years, does that cause thinning of the vaginal wall? And if that is the reason, then what can be done about that?
It can. It absolutely can. So for reasons of cancer, again, going to your oncologist or your primary doctor and finding out could you safely use topical estrogen or not, all right? We say it's safe because it just doesn't get into your bloodstream the same way. There are other ways as well, though, to stimulate collagen in the vagina, and so those can be used as well. So there's devices out there that do radio frequency or CO2 stimulation, and what that is doing is stimulating collagen. So instead of stimulating estrogen, you're stimulating collagen, and changing that into an active form can also improve blood flow and lubrication.
Okay, question. This is kind of more urogynecology, but where did it happen? Is there anything that can be done when the vagina is absorbing waste from the colon? Is it due to thinning of the lining?
Absorbing waste, so I guess that means bacteria?
I would assume so, or maybe it's fecal matter residue?
Unfortunately, estrogen affects all of our sphincters, right? Even the anal sphincter, right? So when I was in my research phase of my training, I did a whole study on fecal incontinence in female physicians. They ran from me. But we were looking at anal sphincters, and unfortunately, the anal sphincter thins as you age too because of anal receptors there. But that question makes me think maybe there's a bacteria issue. So with chronic bladder infections, they do happen more in women who are in past menopause, and we do actually prescribe for women vaginal probiotics to improve the ecosystem. Yeah.
Okay.
So, that's what I'm going to take from that question, yeah.
I was wondering if there's any correlation with if you had your period earlier than your friends. So would menopause start sooner?
It's possible. So if we look at menopause as a result of the follicular depletion, if you start your menses earlier, your follicles are getting used up earlier. So there could be. It's not a guarantee, though.
Dr. Devera, while you're up there, can you just reinforce what the difference is between perimenopause and menopause symptoms?
So perimenopause is when you're still having your menstrual flow. You are still having your menses, but the timing as to how often and when and how predictable your menses are can be highly variable. So as you're going through the menopausal transition, it initially is just very subtle changes, like, oh, it's just plus or minus 7 days now. And then you start to notice the intervals between your menses get longer and longer. Like, oh, now I went 3 months without a period, but then it came back and was monthly again, and then I went 6 months without a period. So the perimenopausal transition usually, I would say the hallmark or the most obvious symptom is those changes in your menses. And then menopause is complete cessation of your menses. There's no more period. You have that final period, you go 12 months or more, and you don't have any period anymore.
So you had said something about if you're in your 60s and maybe not use estrogen because it could be cancer causing?
Or not necessarily starting hormone replacement therapy after the age of 60. So if you've already been on hormone replacement therapy, you started it when you were 50, going through the menopause transition, and we're thinking about weaning you off of it, those risks are considered to be different than being 60 plus and starting your hormone replacement therapy at that age. Yeah, I hope that answered the question.
Also, Dr. Devera, you spoke about prescription hormone replacement therapy. Can it also be, even though it's prescribed, can it still be bioidenticals, although it's not compounded?
Yes, so there's a medication called Prometrium, which is a progesterone that is prescribed, and it is considered to be a bioidentical progesterone. So there could be some, most of the compounded bioidentical hormones are going to need a prescription, but there are some prescriptions that you could pick up, and the one that comes to mind is the progesterone. I don't know if you think of any other ones, but there is a bioidentical progesterone that can be taken, and that's probably the most commonly prescribed progesterone formulation for hormone replacement therapy.
Go ahead.
No, we have to go through the mic. So
Okay.
if you have a question, I'll come over to you and bring the mic so our guests can hear online.
Okay. You talked about a predisposition just a moment ago. So can one, and I'm not sure if this is a good question for you, could be for a medical scientist, but can that predisposition be derailed, so to speak, and because of life behavioral changes? In other words, if your parents had it, your mom, your grandmother, can't you redirect that so therefore you don't continue that behavior?
Yeah, I think the relationship between our environment and our genetics, even outside of menopause, with any really medical or physical characteristic that we have, I think there's a lot of intertwining cause and effect, or the way our genetics and our environment come together, I don't think we really understand well. So you'll see, families that have this strong family history of breast cancer, and then a woman who does not get it. So we control what we can, by staying active, eating healthy. Unfortunately, what we get genetically, we may or may not be able to derail. I think it depends on what we're talking about. What kind of genetic mutation are we discussing, and can environment mitigate those risks that we receive genetically?
Okay. I saw some hands up in this area. Okay. If you don't mind.
Oh, thank you. Okay. I want to compliment you on one thing, but I want to add to it. When you talked about the pharmacist, the one that you go
Bioidentical or compounding?
compound pharmacist. You said that they're not and that's true. They are not regulated by any government agency, and so are vitamins and herbs and teas. People need to know that as well. They think they're safe, but you need to really research that. But the other question I have is, can menopause and having a surgery, I was premenopausal when I had my hysterectomy because they thought I might have cancer. And so can that affect incontinence?
Can a
Cause it?
hysterectomy-
Yes.
So, just so I understand, the question is, can early menopause and having a hysterectomy affect continence or the ability to control your bowel and bladder? I would say absolutely. Yeah.
Okay.
It doesn't mean you're going to have continence issues, but yes, it could potentially put you at more risk. Yeah.
Does menopause affect blood pressure, particularly the systolic number?
I wouldn't say that's directly related to menopause. I think sometimes menopause gets jumbled in with also natural aging. We're talking about an issue that happens in your 40s, 50s, 60s, where there's a lot of other processes going on outside of our hormones, outside of menopause. So we do see issues like hypertension, diabetes become more prevalent as we age. So it's probably more so in regards to that versus specifically menopause and the changes in hormones.
So if your doctor prescribes estradiol, or
Estradiol.
thank you, estradiol, and physical therapy for stress incontinence, and you mention on the vaginal cream that if you have your uterus, do you also have to be on progesterone? Or
Not
Okay.
for vaginal estradiol.
Okay.
So the type of vaginal estradiol that's given to help with dryness, lubrication, specifically for vaginal health, does not have to come with progesterone.
Okay, we have got a question about the thickening of the uterus and being treated with Provera due to perimenopause. Is there thickening of the uterus if someone's being treated with Provera due to perimenopause? She's thinking.
Yeah. So I think that question is addressing the endometrial lining, the lining within the uterus that sheds monthly with our menstrual flow. That lining can thicken. When it thickens, it can lead to issues like precancer of the uterus, in worst case scenario, cancer of the uterus. So Provera can be given as a protective medication to treat that or to reduce the risk. Was that the question?
Yeah. And we have another online question, and that's, would perimenopausal women who are 65 plus, not sexually active, visit her gynecologist to check for uterine cancer? If so, how frequently? And how is TEDTOMF, TEDTOMF, done when a pelvic exam is very painful?
It sounds like a two-part question.
Yeah.
If you're 65 and over, yes, you should still be going to see your gynecologist just for your routine well woman exams once a year. In regards to checking for uterine cancer, there's really not a screening test for it. We only have a couple cancers that we actually have screening tests available for. Mammograms for breast cancers, colonoscopies or fecal occult blood testing for colon cancer, and pap smears for cervical cancer. Many of our cancers, there's really no screening test for, meaning a test that can be done to prevent it or to detect it in early stages. Uterine cancer is one of probably the better cancers to get because it has a high survival rate. The number one symptom to trigger women to come in and see us would be vaginal bleeding, especially if it's after menopause. Vaginal bleeding after menopause doesn't always have to mean you have cancer. It could be something as simple as atrophy that needs vaginal estrogen treatment. But without symptoms, there's really not a screening test for uterine cancer. I'm not sure what the second part of the question was coming to. If pelvic exams are very painful, there are some things that can be tried. Sometimes I've given patients a prescription for lidocaine gel. She can insert it at home when she's on her way to the office, and by then it's working so I can do her pelvic exam. Speculums come in different sizes, so for some of my patients who have really significant atrophy, stenosis of the vagina, I'll have to use like a tiny pediatric speculum. So there are some ways to try to make that pelvic exam more comfortable for patients.
Listen, I do recognize that there are some hands. We can still take questions afterwards, but want to be cognizant too of everyone's time. Thank you very much for coming, but mostly thank you guys very much for speaking with us. It's quite evident that, this is your area of expertise, and we just so appreciate you sharing your time and thoughts with us, so thank you. For everyone else, please, if you don't mind, fill out the questionnaire. We want to know what you want to hear. Next week, we are also having a program on weight management, and that you're more than welcome to attend live or virtually as well. And then in May, we will be hosting an event on stroke based on feedback. So thank you very much. Thank you, ladies. Have a great evening, and thanks again for coming.